Good afternoon to all of our listeners. My name is Carmen Wu, and I'm one of the advisors at Egan, Berger & Weiner. First, I would like to thank you for joining us to this webinar, Planning for Healthcare in Retirement. We are going to be looking at Medicare, Medicare supplement policies, and Medicare Advantage, along with a discussion of potential costs. As mentioned in our invitation, you will learn 4 steps you can follow to incorporate it into your overall financial plan. John Driscoll, he is our presenter today, and he is Vice President for Fidelity Financial Advisor Solution, a division of Fidelity Investments. He joined Fidelity Investments in 1997 as an inside wholesaler for advisory wholesaler team. Prior to his role with the sales force, he was a relationship manager with the Fidelity Charitable Gift Fund in Boston. He attended Boston College, where he received a degree in economics. Now, we will make sure that we leave plenty of time at the end to answer any questions you may have. Now, due to compliance requirements, I'm asking that you please email your questions at the following email: hpressman@ebwllc.com. Again, that's hpressman@ebwllc.com with healthcare as a subject line. Now I'll go ahead and turn it over to John.
Thank you, Carmen. Good afternoon, everybody. Thank you for taking time out of your day to join us to talk about this important topic, Medicare, a program that most of you folks will be enrolling in at age 65 or when you terminate service from your employer. And you might be thinking, why is Fidelity here with EBW talking about Medicare? What's the connection? And the connection is, at Fidelity, we have a very large 401k platform. So we have an interesting perspective. We have a bird's eye view of watching people save for retirement, invest for retirement, and ultimately make that transition from work to retirement. And what we have found is that a lot of folks, when they first transition into retirement, they're concerned about their assets, their nest egg, and that's perfectly natural. You might be thinking, have I saved enough? Am I on track to retire when I want to? How long is this portfolio going to last? Who can I work with to make sure that my nest egg is going to last for 20, 25, 30 years in retirement? And then above and beyond that, there are some unique, interesting topics that people have to make important, often permanent decisions, and those 2 big programs are Social Security and Medicare. So at Fidelity, we're a mutual fund company. We have no vested interest in Medicare. We do not sell supplemental plans or Medicare Part D plans or Medicare Advantage plans, but knowing that this is an important topic, what we have developed over the last few years is a presentation geared towards pre-retirees. So we can go through this presentation. So we're not going to, an hour from now, maybe not know every single minutia that there is to know about Medicare, but we'll have a better idea of how this program works, what it covers, what it doesn't cover, and how you can accurately estimate what your out-of-pocket expenses are going to be when you ultimately enroll in Medicare. So the presentation that we're going to go through today is, we're looking at the agenda here. We got 3 bullet points. The first one is we are going to gain some general insight into healthcare costs, just general costs and what we're seeing in the industry and some industry trends from 30,000 feet. The second bullet point is we are going to take a closer look at Medicare, and we're not going to cover everything there is to know about Medicare, but we are going to go through the major components like Medicare Part A and B and D and Medicare Part C, so everyone has an idea of how these programs work, again, what they cover, what they don't cover, and what your potential out-of-pocket expenses. And then lastly, what Carmen alluded to is the 4-step process. How can I, as an individual, sit down, knowing what I know about Medicare now, ultimately accurately estimate what my out-of-pocket expenses are going to be when I enroll in Medicare. So that's the general outline. So I guess we'll transition to that first bullet point, and that is just gaining some general insight as to healthcare trends from about 30,000 feet. So what we're looking at on this slide, if you look at the blue line, is this is a very basic chart. This is not going to surprise anybody on this call. And what we're looking at since 1984 is a chart of inflation. So if we go back to 1984, and we go out to the general economy and we buy a basket of goods and services for $100, and then we fast forward all the way out to 2014 and we go out to the general economy and buy the exact same basket of goods and services, we know it's going to cost a little bit more, and generally right about $233. So if you look at that chart and if you sit down and you do the math, that is a year-over-year inflation rate of 3%. And the reason I don't think this number is going to surprise anybody is because inflation over the last 100 years or so has been right around 3%. Now, if we back out just the cost of goods and services in the healthcare sector, we know that since 1984, it's been growing faster than general inflation. Go back to 1984, what we could buy for $100 in the Medicare sector, you fast forward to 2014, and that same basket of goods and services in the healthcare sector is going to cost about $440. So if you do the math on the healthcare sector, that is a general inflation rate of about 6%, or twice the rate of general market inflation. So what we're looking at on this slide is if we look at a typical retiree. Now, I know everyone on this call is a little bit different, but if we look at the typical retiree across the United States, we're looking at the three largest expenses that the average retiree has. And oddly enough, number one is food, and that kind of surprises some folks, but if you think about it, breakfast, lunch, and dinner for you and your spouse for the rest of your life, it kind of adds up. Healthcare on average is number two, and housing is number three. The reason housing is number three is because a lot of folks have their home paid for by the time they reach 65, 70, so that brings down the average number a little bit. And if you go back about 40 or 50 years, healthcare was not the second largest expense. It was about the fourth or fifth largest expense, but because it's been growing at twice the rate of inflation, it snuck into that number two spot. So a couple anecdotal bullet points, and I'll cover these very quickly, but if you look on the left-hand side of the screen, medical services, the cost of knee replacements has risen about 70% over the last decade. And one additional stat I will share with you very quickly is a couple months ago I saw another stat on knee replacements, and it was a similar number, but it was a different study. And the stat that I saw a few months ago was, it said the number of people getting knee replacements over the last decade has gone up about 70%. So that was interesting. I think a couple factors may factor into that. People have had more active lifestyles. Obesity might be a little bit of an issue in the United States. And you also have a huge demographic of folks born between 1946 and 1964, baby boomers, that are starting to reach the age where, you know what they need? They needed knee replacements. The middle bullet point, diagnostic testing. The cost of MRI, CAT scans, and PET scans has tripled over the last decade. And typically this is great, groundbreaking technology that extends our lives and extends the quality of our lives. But when this groundbreaking technology comes to the forefront, it's typically not inexpensive. It's typically a little bit more expensive right on the initial onset. And then lastly, on the right-hand side, prescription drugs. The number of prescriptions continues to grow. It's up 55% from 1998 through 2013. So those are just some general bullet points and themes that we're seeing in the healthcare space from 30,000 feet. Where does that leave us? We got a few numbers on this slide, and the number I'm going to point out here is in the green box in the top right-hand corner. And that number is $220,000. And what we're looking at here is a study that Fidelity does every single year. And again, Fidelity has no vested interest in the Medicare space. We don't sell supplemental plans or Part D plans, but we know that this is a big concern for pre-retirees, so we want to know folks that are prepared for this. And the number I'm referring to is if we look at a 65-year-old couple that's retiring today or in the near future, we think they're going to need roughly $220,000 out of pocket to supplement Medicare, not including long-term care. So that's a big number, $220,000 out of pocket to supplement Medicare, not including long-term care. And you might be sitting there thinking, well, what are we looking at? And what we're looking at is a husband and wife. The man lives for 17 years, the woman lives for 20 years, and they enroll in original Medicare, and that is Medicare Part A, Medicare Part B, Medicare Part D, and a Medigap plan. And if you count up all of their out-of-pocket expenses in the form of deductibles, co-pays, and premiums, over their lifespan, we think it's going to pretty accurately add up to about $220,000. So you're going to have to take my word for it, but as we go through this presentation, when we get to the end of the presentation, after covering those 4 components, you'll see exactly how we get to that number. Now, some good news, your number could be certainly lower than that. It could be a lot lower than that, and that could be based on personal factors, such as your age at retirement, your years in retirement, and of course, your general health. And then on the right-hand side, your number could be a little bit higher or a little bit lower based on your risk comfort level. And what I mean by that is how much insurance do you want to buy, or how much do you want to self-insure and maybe roll the dice a little bit and pay out of your pocket as you go. So you have some choices in the Medicare system. So we're now going to get into, I guess, the meat of the presentation. And we got 4 steps here. And what we're going to do today really is we're going to cover steps number 1 and 2. And that is we are going to get to know Medicare. And number 2, we'll spend some time there where we're going to go through a case study so you folks can see how on the back of an envelope you can accurately estimate what your out-of-pocket expenses will be. Steps number 3 and 4, that's going to be up to you and EBW to figure out, because I can't sit here and say that there's a magic solution for everybody. Everybody's situation is a little bit different, and how you structure your portfolio to pay for essential expenses in retirement is going to be different for everybody on this call. So I'm sorry to say this, but all of you are going to have a little bit of homework, because we're going to cover steps number 1 and 2, and steps number 3 and 4 will be for you and EBW to talk about it at your next follow-up meeting. So step number 1, we got to get into the meat of Medicare, and what we're looking at here is the alphabet soup of Medicare. And we're going to cover this in the order that you see on the slide, and we're going to spend most time on what most people do. And when you enroll in Medicare, you have a choice. You can go down the road of original Medicare, and that's what most folks do. And original Medicare is signing up for Part A, Part B, Part D, and a Medigap plan. You're going to take those 4 components, put them together, and you're going to have comprehensive coverage in retirement. Your other option is to get a Medicare Part C or a Medicare Advantage plan. And I think the percent of people in Medicare today, it's roughly 70% of people go down the road of original Medicare. And it's about 30% of people that say, you know what, I want a different option. I'm going to go out and get a Medicare Part C plan. We're going to cover Medicare Part C at the end. One thing you're going to want to keep an eye on is over the next 10 years, part of the Patient Protection and Affordable Care Act, government funding for Medicare Part C is projected to go down a lot. So if that happens, government funding for Medicare Part C, if that goes down, a couple things could happen. Number 1, premiums for Part C plans could go up, or they could restrict the amount of services that Part C plans cover, or it could be some sort of combination of the two. So if government funding goes down dramatically, what we could see is that these Part C plans may look less attractive 5, 10, 15 years down the road. So we will cover Medicare Part C at the end, because it does have very clear advantages, but at the onset we will focus most of the time on what most people do. So we'll start at the top, and we will start with Medicare Part A, and Medicare Part A is your hospital insurance. Some people refer to it as emergency insurance. So if I'm a 65-year-old retiree, I enroll in Medicare. 3 months later, I get in my car, get into a car accident, break my leg, and get wheeled into the emergency room. If I have Part A, I'm covered, okay? So this is going to cover you if you're admitted to the hospital. Now, a little bit of good news with Medicare is if you have been paying your FICA taxes and you are 65 years or older, and a U.S. citizen or a permanent resident, your premium for Medicare Part A is going to be 0. So that's some good news right there. Medicare Part A, some people may refer to it as free, but you have been paying those FICA taxes over the last 30, 35 years, so you can think of it as no additional cost. Either way, when you transition into Medicare, the premium should be 0, but if you get admitted to the hospital, you may have out-of-pocket expenses. So if you look at the slide, that top row there, days 1 through 60, if I break my leg and I get wheeled into the emergency room and I'm admitted to the hospital, I have to pay a $1,260 deductible before Medicare picks up the first nickel. So if you were to think about this, hypothetically, I'm sure this is not going to happen, but your neighbor tomorrow morning gets into their car, gets into a car accident, breaks their leg, gets wheeled into the emergency room, try to think about how quickly it takes to rack up only $1,260 in an emergency room. It does not take long. So the key theme from Medicare Part A that we'll take away from this slide is, for most of you folks on the call, I'm going to go out on a limb and say most of you, if not all of you, are going to be eligible for Part A, and the premium is going to be $0. That's the good news. The bad news is, although it's free to have, it's not free if you actually have to use it. One other thing I'll just quickly add with Medicare Part A is the deductible you're looking at of $1,260. That is not per year. It is per visit or per benefit period. And a benefit period is you're admitted to the hospital. You're there for, say, 3, 4, or 5 days. Once you get released from the hospital and remain out for 60 consecutive days, your benefit period ends. So in theory, you could have multiple benefit periods in the same year. Either way, the key takeaway is, for most of you folks, Part A is going to be free, but not free if you actually have to use it. Next in line, we got Medicare Part A, and on this slide, you're going to see a bunch of numbers on this slide. So it may look a little confusing at first, but what I want you to do is, if you would focus on those highlighted yellow numbers on the right under premium. And Medicare Part B, this is going to cover all of your day-to-day medical needs when you're not admitted to the hospital. So what I mean by that is, this is going to be your typical doctor's visits, CAT scans, x-rays, preventive screenings, rides in the ambulance to the hospital. And there was a big change to Medicare Part B back in 2010, very big change. Prior to 2010, the premium that people paid for Part B was a flat rate premium across the board, no matter where you lived or what income bracket you were in. I think in 2009, 2010, it was around $88 per month. In 2010, the government said, this program's expensive, we're bleeding assets, we need to raise revenue, so they basically implemented means testing in 2010. And what I mean by that is, the premium you pay for Medicare Part B is based on your modified adjusted gross income. So if you look at the middle column where it says Joint Filer AGI, this would be the column if you're filing a joint tax return. And obviously on the left-hand side under Individual Filer AGI, that would be the income brackets if you're an individual filer. But we'll focus on the middle column. We're going to assume that we have Mr. and Mrs. Smith. So they file a joint tax return. So we're going to look at that middle column under Joint Filer AGI. Depending on where their modified adjusted gross income falls, that is going to determine their premium, which is per person per month. What the IRS does is, every year you enroll or re-enroll into Medicare, it's always a 2-year look back where they're going to look at your tax return from 2 years ago. So for folks that just enrolled for 2015, the IRS looked at their 2013 tax return, and that determined what their premium would be for 2015. And when they re-enroll for 2016, they'll be looking at their 2014 tax returns. It's always a rolling 2-year look back. So we have the premium, which again is the result of a little bit of means testing in 2010. On top of that, in the top row there, those numbers are a little bit small, but you'll see a $147 deductible. Now that's an annual deductible, so that's not that bad. But there's also a 20% coinsurance or 20% copay that you pay out of pocket for any approved service that's covered by Medicare Part B. And again, a short laundry list would be doctor's visits, CAT scans, x-rays, preventive screenings, rides in the ambulance. One thing you may want to take note of is, during your working years, if you're in a higher income bracket and you think that's going to drop a bracket or two in retirement, the good news is, although you may be paying a higher premium in the first year or two in retirement, those working years will eventually roll off, and you should drop down a bracket or two for your Medicare Part B premiums. If you have 1 year at the end of your working years that is an outlier, you have a big tax year, you either make a lot of money, you sell a business, you sell a piece of property, you do a Roth IRA conversion. If you have 1 year that is clearly an outlier, you can petition Medicare to get an exemption for that 1 year. And I know some folks that have done that. It involves a little bit of paperwork, but it is something that you can certainly try to do if you have 1 year that's clearly an outlier. So we've covered Medicare Part A, Medicare Part B. Next in line is Medicare Part D. And what we're looking at here, Medicare Part D is going to be for prescription drugs, and there's going to be a dark blue pop-up box here that's going to pop up on the left-hand side. And in that box, there's going to be a term that a lot of you folks have probably heard of, and that is the donut hole. And the donut hole represents a formula that Part D plans are based on, and most folks that I bump into have heard of the donut hole, but they're not really sure exactly how it works. They just know it's confusing, and it can result in a lot of out-of-pocket expenses when they go to the pharmacy. So what we're going to do is we're going to go through this bar graph, starting at the bottom, going up through the top, and I think this should give you a better idea of how this donut hole formula works. Assuming I'm 65 years old, I retire, I enroll in Medicare, I'm going to be smart, and I'm going to go out and get a Medicare Part D plan for prescription drugs. And you have a lot of choices. These are all offered by private insurance companies. And at the lower end of the scale, I can get Part D plans for under $10 per month. Now, they don't cover as many drugs, but you can get cheaper Part D plans. On the other end of the scale, we have Cadillac plans that cover a lot more drugs. And the premiums for those plans are about $90 per month. Now, the average premium people paid in the United States was $39 last year. So we're going to say that I'm that typical average retiree. I'm paying $39 per month, so I have prescription drug coverage. So January 1st, we're going to start at the bottom of that bar graph, and I hope visually you folks will be able to follow along with me. January 1st, I start going to the pharmacy. I'm filling prescriptions right off the bat. I have to pay a $320 deductible. I have to satisfy that deductible before I get any coverage. So looking at this bar graph, everything in green comes out of my pocket. Everything in blue is picked up by the insurance carrier. So step number one is I have to fulfill that deductible of $320. And if I take 2 or 3 prescriptions, that shouldn't take too long. And now the good news is I have coverage. And you'll see that the insurance company typically picks up about 75%. And I, as the individual, I'm going to be on the hook for a 25% copay. So this is good news. I mean, my insurance carrier is picking up 75%. I mean, that's the lion's share of the prescription drug expense. The catch is with the donut hole is January, February, March, April, May, June, July, August, throughout the year, when it gets to the point where the combined dollar amount between what the insurance carriers chipped in and what I've chipped in, when that combined dollar amount reaches $2,960, I have reached the donut hole, and now I pick up 100% of that prescription drug expense out of my own pocket. So if you look at the middle part of that bar graph where it says limited Medicare coverage in the donut hole, that's the donut hole. In worst case scenario, if I take a lot of prescription drugs and they're very expensive, I can be in the donut hole for up to $3,720. And if I go all the way through the donut hole, you'll see at the very top, the insurance company comes back in and says, look, you have paid enough out of pocket, you've satisfied the donut hole, we're now going to come in with catastrophic coverage and basically pick up the whole thing, or roughly 95%. So a very quick recap on that formula is, again, you need to pay monthly premiums to have a plan. And then January 1st, when you start going to the pharmacy, you have a deductible. Then you have co-pays up to $2,960, and that's when folks are impacted by the donut hole. So one theme that I hope you folks take away from today's presentation is, I certainly did not wake up this morning, jump out of my bed, clap my hands, and get all excited about telling people how expensive Medicare is. That's not the theme of today's talk. Today's theme is resources. So we're better educated to make better decisions when we first enroll. And one great resource for Part D plans is going to be on Medicare.gov. And if you folks, and I know a lot of you folks are not even close to retirement, so this might be a great resource for older relatives or parents or coworkers. On Medicare.gov, there's a donut hole calculator. And what an individual can do is they can sit down in front of this calculator, they enter their zip code, the prescriptions they take, how often they take them. It is a 15 or 20-minute exercise, but once you go through those steps, the calculator is going to do 3 things for you. Number 1, you'll have a better idea of how this donut hole formula works. Number 2, you'll have an idea of what your out-of-pocket expenses will be for the coming year. And then number 3, this is the best part, it's going to lead you to Part D plans that are the best fit based on where you live and what prescriptions you take. So that's a phenomenal resource on Medicare.gov. One thing I will add to Medicare Part D is the Patient Protection and Affordable Care Act, which is something that we've all heard of almost every day for the last 5 years. It does not have a major impact on Medicare, but there are some subtle impacts, and one of those subtle impacts is the donut hole between now and the year 2020 is going to be phased out. And when I tell that to people, they seem to get a little excited because they think, okay, that's good news. I think it's a little bit of good news and bad news. The good news is when it's fully phased out after the year 2020, there is no donut hole abyss that I can fall into. There's no crazy formula that I have to try to follow, and I'll never get surprised going into the pharmacy where I have to pick up 100% of that prescription drug expense. That's the good news. The bad news is private insurance companies that are offering Part D plans, once the donut hole goes away, they're still going to make a profit somewhere. So we may see premiums may go up, we may see the deductible go up or copays go up. Either way, our out-of-pocket expenses may not go up or down that much. So that's maybe the bad news, but the good news is the donut hole formula in about 5 years shouldn't be around anymore. So we've covered the lion's share of original Medicare, and again, we've covered Medicare Part A, Medicare Part B, and Medicare Part D prescription drugs. And what a lot of folks do is when they get close to age 65, they realize a couple things. And the first thing they realize is, gosh, Medicare is not free. I thought Medicare was free. Medicare is certainly not free. And the second thing they realize is, you know what, if I get particularly sick, or if my spouse gets particularly sick, our costs can go through the roof with multiple hospital deductibles, 20% copays that don't have a cap, this donut hole formula that I can fall into. Our costs can really spiral out of control. So wouldn't it be great if there was a way that we could go out to the marketplace and get an added layer of insurance protection? And that comes in the form of a Medigap or supplemental plan. And Medigap and supplemental plan are just 2 different words for the same thing. So on this slide, on the top row, we see that we have 10 standard plans that we can choose from. And all of these 10 standard plans that we can choose from are lettered A through N. And just like Part D plans, these are regulated by the government, offered by private insurance companies. So as the consumer, I do not have to get a supplemental plan, but most people do. They either have a supplemental plan or they're getting some form of supplemental coverage from a former employer or through a government program. But either way, most folks have an added layer of insurance protection, and if it comes in the form of a supplemental plan, what you do as the consumer, again, you don't have to pick one, but virtually everyone does, you look at your 10 levels of coverage. You got the junior plan all the way ranging up to the Cadillac plan, and as the consumer, you think about your risk comfort level. How much insurance do you want to buy? And you look at your 10 options, you pay a premium for the supplemental plan, but what the supplemental plan does in return is it helps pick up your out-of-pocket expenses with Medicare Part A and Medicare Part B. So that was, I guess, maybe step number 1 of the presentation. And what we're going to do now is we're going to transition into the case study. Okay, and this is where if you have a piece of scratch paper or a legal pad nearby or literally the back of an envelope, if you want to jot down some of these numbers, this is the process or the framework that folks can use at age 63, 64, 65 to accurately estimate what are my out-of-pocket expenses are going to be when I transition to Medicare. So what we're going to do here is we're going to go through a case study, and on the right-hand side of the slide, we see that our retirees are at their retirement home, looking over the beautiful blue ocean somewhere in a nice tropical island. They're probably holding umbrella drinks. And they're about to turn 65. They are about to enroll in Medicare. And you'll see in the top row there, we're going to assume that their income in retirement is typically going to be under $170,000 of modified adjusted gross income. Some folks on this call, your number could be a little bit higher, it could be a little bit lower, which we'll cover after we go through this case study. But for these folks, for across the United States, we think this is a fairly typical case study. So we'll stick with these numbers for now. So Mr. and Mrs. Smith, they are about to turn 65, and they've realized a couple things. They've realized that Medicare is not free, and they've also realized once they enroll in Medicare, if they have a particularly bad year health-wise, their costs can go through the roof. So what they're going to do is they are going to do what most folks do, and they are going to have an added layer of insurance protection. So we're going to start, if you want to jot these numbers down, we're going to start at Medigap plans, which is the fourth row. And so what these folks are going to do, they're going to be smart. And again, you don't have to get a Medigap plan, but they're going to choose one. And if you remember from the last slide, we have 10 Medigap plans we can choose from. When we do our case study, we always use Medigap Plan F, as in Frank, for a couple reasons. Number one, it is by far the most commonly selected Medigap plan. It also offers the broadest coverage, so that's good news. A lot of folks consider it the Cadillac plan. Now, the bad news is, as the name would suggest, the Cadillac plan, it's not the cheapest one. It's typically the most expensive one, depending on what state you live in. The average premium across the United States for folks enrolling at age 65 is just over $180. So if we take, I think it's $182, we multiply it by 12, and we get to roughly $2,180. So the first number I'm going to ask you to jot down is for Medigap. If you would just jot down $2,180, okay? Now, that premium will eventually creep up for folks that enroll at age 66, 67, 68. It does go up as you age, but for folks at age 65, that's going to be the typical premium. Mr. and Mrs. Jones every year have to sit down and write this check, and they don't enjoy writing this check. They don't look forward to it, but the reason they write this check is because if they don't have a Medigap plan, they could be writing a much bigger check down the road to the hospital or a doctor if they get particularly sick. So the Medigap plan, think of it as peace of mind. I can sleep at night. I have my added layer of insurance protection. So we're now going to go from Medigap plans up to the first row, which is Medicare Part A. And Medicare Part A, if you remember, is your hospital insurance. Now, both of these folks, when they turn 65, they will be 65 years old. They will be U.S. citizens or permanent residents. They've been paying their FICA taxes, their Medicare taxes. So when they turn 65, their premium for Medicare Part A is going to be a big fat goose egg. It's going to be zero. Now, you might be thinking, with the hospital, if they get admitted to the hospital, there's a $1,260 deductible. Who pays that? Well, if you think about this, hypothetically, if Mr. Jones 6 months from now gets into his car, gets into a car accident, breaks his leg, and gets wheeled into the emergency room, you might think that Mr. and Mrs. Jones are on the hook for $1,260, but they were smart and they got that Medigap plan. So Medigap Plan F in most states, which is the Cadillac plan, in most states it's going to pick up 100% of the deductible 100% of the time. So if they have if they're admitted to the hospital once, twice, or 3 times in the same year, that deductible is going to get picked up by Medigap Plan F. So if you're following along on Part A, you can fill in a big fat goose egg, which would be zero because they have that Medigap plan. The next one we're going to look at is Medicare Part B, B as in boy, and you might remember this is your medical insurance, which is doctor's visits, CAT scans, x-rays, preventive screenings. And this is where we see a little bit of means testing from the government. And you'll remember that the premium is based on your modified adjusted gross income. So these folks are in the first standard bracket, which is a joint tax return of modified adjusted gross income under $170,000. So if they're in the first standard bracket, their monthly premium is $104.90 per month per person. So $104.90 times 12 months, we get to $1,259. Now you might remember with Medicare Part B, you have a $147 deductible and a 20% copay. So if you think about this for a second, if Mrs. Jones 9 months from now is doing a little gardening, she's pruning a tree, she falls off a ladder and breaks her arm, she's going to have a doctor's visit with a 20% copay. She's going to have an x-ray with a 20% copay. She may have physical therapy for a 20% copay, but they are not going to have to pay that because that's going to get picked up by Medigap Plan F. So you'll see, hopefully you have a better idea of now of how that Medigap plan, although it's not free, it helps pick up your out-of-pocket expenses with Parts A and B. And if you get particularly sick, paying that premium for Medicare for Medicare Plan F or another Medicare plan can save you a lot of money. So the last number we're going to plug in is for Medicare Part D, and the number that we use is the national out-of-pocket average expense people had with their Part D plan across the U.S. last year. So if you look at someone with a Medicare Part D, if you add up their premiums, deductibles, co-pays, on average, across the U.S., on average, a person with a Part D plan had out-of-pocket expenses of $2,014. Now, if you folks want to get a better idea of what your number is with Medicare Part D, you can go to Medicare.gov, donut hole calculator, and do that 15, 20-minute exercise. It will spit out a number, and you can plug it in, and you'll have a more accurate number as to what your number is. So Mr. and Mrs. Jones, they have done this exercise on the back of an envelope, and we got our numbers here, so we're going to add up A, B, D, Medigap Plan F, and it equals $5,453 per person multiplied by 2 for a couple, and we're at $10,906. So once we have a better idea of what this expense is, now we can have a more thorough conversation with our financial advisor, because for this essential expense and other essential expenses, Fidelity and a lot of other companies out there in the financial services space, we recommend covering your essential expenses with guaranteed or a highly predictable source of income. And I can't really talk about a solution right now because everyone's situation is a little bit different and everyone's portfolio is going to be structured a little bit differently. So that's why we have a little bit of homework. And for your next conversation with the EBW team, this is something you may want to talk about, and then review your portfolio to make sure you're on track to meet this expense and pay for this expense and for hopefully a 25, 30, 35-year retirement. So we've gone through a lot of numbers very quickly, and when I do this live for a live audience, what has happened in the past is some people will come up to me afterwards and said, you know, we did a hypothetical case study. But that's for a hypothetical couple. How can my number be a little bit different? So if you look at these numbers on the screen, what I'm going to do now is very quickly talk about how your number could be a little bit higher or it could be a little bit lower. So when you do this exercise later tonight, in a couple months, in a couple years, you can get a better idea of what the variables are. So what we're going to do is we're going to start with at the top to see how that number can vary. If you're eligible for Part A, Part A premiums are going to be 0, so you're not going to see that number fluctuate too much. For Medicare Part B, this is where we see a little bit of means testing, and we see that the premium is based on your modified adjusted gross income. So if you folks are in a higher bracket, your premium can be a little bit higher. So the first variable for Medicare Part B is if you're not in the standard bracket, your premium is going to be a little bit higher. So that's the first variable. The second variable is with Medicare Part D, as in David, prescription drug plans. The number we use, just as a reminder, was the national average. If you take more prescriptions than the typical retiree, your number could be a little bit higher. But if you take fewer, and if you're just transitioning into retirement and you're younger, healthy, and you don't take any prescriptions, that number can be dramatically lower. So that's the second variable. And then the third variable is Medigap Plan F. You have 10 choices, and we're looking at the most expensive one, and there's nothing wrong with the other 9 options, but if you pick a supplemental plan that doesn't cover as much, that premium is going to be lower, and you could save a little bit of money there as well. So those are the different variables when looking at original Medicare. And what I'm going to do now is I'm going to transition to Medicare Part C, which is Medicare Advantage plans. And what we've reviewed so far is, again, original Medicare, which is going to be Medicare Parts A, B, D, and Medigap. And what a lot of folks do is they'll say, you know what, I want another option. And this is about 30% of people in the Medicare system. They will go out and get a Medicare Part C or Medicare Advantage plan. Now, if you're getting a Medicare Part C plan, you're also going to enroll in Medicare Part A. You're also going to enroll and pay for Medicare Part B. And then on top of that, you're going to get a Medicare Part C plan that basically will act as your prescription drug coverage and your supplemental plan. So here are some pros and cons of Medicare Part C versus original Medicare. Some of the advantages is with Medicare Part C, it's one-stop shopping. So a lot of folks will think of it as a bundled solution where you're going to a private insurance company, you're buying one plan, and it basically replaces having to sign up for A, B, D, and Medigap. So one-stop shopping, ease of doing business, some people find that attractive. The other advantage is, and this is an advantage and a disadvantage, is you're going to be participating in an HMO. So you're going to be dealing with doctors within a network. Now that's an advantage because if you've been working and participating in an HMO during your working years, you kind of have an understanding of how that program works, and if you're comfortable with it, that can certainly work for you in retirement, but you have to remember that's dealing with doctors within a network. The disadvantage that comes with an HMO is you're dealing with doctors in a network. And if you do a lot of traveling, like my own folks do, they spend part of the year in the Northeast, they spend part of the year in Florida, they do a lot of, or not a lot of trips, a couple of trips throughout the year. If they have to see a specialist on the road outside of their network, that could really result in significant out-of-pocket expenses. So for some folks, Medicare Part C is just not flexible enough for them. So you just have to realize the pros and cons of participating in an HMO. Another advantage with Part C, and I think this is what drives a lot of consumers to purchase a Part C plan, is premiums for Part C can be very, very, very low. And I know in some states they can be as low as $0. And your maximum out-of-pocket expense is regulated by the government, and it cannot exceed $6,700. So if you look at those numbers from 30,000 feet, you might say, okay, I can get coverage for free, and if I don't get sick, I'm not going to have any out-of-pocket expenses because I don't have to go to the hospital, go to the doctor, so it's going to be free. And worst-case scenario, it's only $6,700. The catch to that is the $6,700 cap does not factor in, you have to pay for Medicare Part B premiums, which if you're in the first bracket is going to be $1,259. It does not factor in the premium you pay for Medicare Part C. So let's say you're paying $50 per month. That's another $600 per year. And it does not include your out-of-pocket expenses for prescription drug coverage. So if you go to the pharmacy and have, say, $1,000 of out-of-pocket expenses, if you add up that max of $6,700, $1,259 for Medicare Part B, your premiums for Part C, and $1,000 for prescription drugs, you're bumping up against $10,000 per person. Now, that's worst case scenario. But the one thing I hope you take away about the clear difference between Medicare Part C and Original Medicare is Original Medicare, particularly if you have Plan F, the Cadillac plan, you go in January 1st every year pretty accurately knowing what your number is going to be. And so you can think of Original Medicare as the known, where Medicare Part C is the unknown. So if you have friends that are if they have Medicare Part C, if they love their Medicare Part C plan, I'm going to go out on a limb and say that they are generally very healthy because they don't have to use their Part C plan, they don't have out-of-pocket expenses. If you bump into someone with a Medicare Part C plan and they're unhappy, they've probably had a couple health incidents and they've realized that their out-of-pocket expenses can add up pretty quickly. So Original Medicare is known, where Medicare Part C, you go into the year not really knowing, and it's more of an unknown of what your out-of-pocket expense could be. So there's some very clear differences between the two. And again, we have to keep an eye on Medicare Part C plans and see how they may change over the next 5 to 10 years. So that was hopefully an overview, and you learned a little bit something about Medicare and a little bit more informed when you make those important decisions at age 65 or when you terminate service from your employer after age 65. And I think what we're going to do now is have a short pause and transition into a little bit of Q&A. So we're transitioning into Q&A right now, and the questions are going to be loading up on the screen here very shortly. The one other impact of the Patient Protection and Affordable Care Act I did not mention that I'll just throw out there right now is, I'm sure you've all heard a million times that you cannot be turned down for an existing or pre-existing condition when you enroll in a healthcare plan. As that pertains to Medicare, you cannot get turned down for a Medigap plan for an existing or pre-existing condition when you first enroll. And what I mean by that is when you first enroll, you cannot be turned down for an existing or pre-existing condition. So what some folks try to do is they'll say, I'll get a junior plan now when I first enroll, and when I get on later on in my years where, 75, 80, 85, where I'm more apt to use my Medigap plan, I'll just trade up to the Cadillac plan. You can certainly try to do that. However, when you trade up, there is no guaranteed issue. You can be subject to underwriting, higher premiums. They may turn you down altogether. Now, if you have a very clean health history, they'll take you on as a new customer, but it's not guaranteed issue. So choosing that Medigap plan when you first enroll at age 65, it's an important decision. So I think we have a couple questions here. And let's see. So the first question we're looking at here, is it true that some plans exempt formulary drugs from the deductible so that depending on your prescriptions, you may not actually have to pay the deductible and just a small copay? Some of these plans are a little bit different, and one resource that I'm going to share with you right now is really the local experts for any really specific Medicare question. There are local Medicare offices scattered throughout the United States. I know that there are 25 of them in the state of Virginia alone, and I know there's one locally in the Fairfax County. So if you go to Google and you Google Fairfax County Area Agency on Aging, it's going to pull up the local office that you can reach out to, and I think the team at EBW will be more than happy to work with you to get in contact. So if there are a couple questions that I can't answer, we do have another local expert resource that we can lean on. So some prescription drug plans do differ a little bit, and I believe there's even some premium Part D plans out there where you're not even subject to a donut hole formula at all. You're going to pay a much, much higher premium for that predictability. But as far as formulary drugs, that is, I can't really give you a detailed answer on that question. So the local office in Fairfax County might be able to help us out a little bit better. The second question here, is it true that you can switch Part D plans if your medication situation changes? What schedule of change is permitted? And the short answer is yes. You can change Part D plans. So when you first enroll at age 65, if your situation changes at age 70 or 75, you take different prescriptions, you take more prescriptions, you can change. And that would be during open enrollment, which is typically mid-October through early December. And that resource that we talked about, Medicare.gov, the donut hole calculator, that is a phenomenal resource and a great exercise to do every single year, because not only do these plans change, but you change. So it's a great exercise to do every year, and again, it will lead you to Part D plans that are the best fit for your situation. So if your situation does change, you can change during open enrollment to a different Part D plan. Let's see, the next question is, can you change your plan from year to year? And the short answer is yes, you can. So this is kind of a two-part answer, and the first part is, let's say we're in original Medicare, and we want to change our Part D plan, or we want to change our supplemental plan. The short answer is yes, you can do that. Again, it's during open enrollment. One thing you want to remember is if you're changing your supplemental plan, you're not guaranteed to get issued that new plan. So if you do have a health history, you can be screened out for existing or pre-existing conditions. So you have to keep that in mind. So when you're first enrolling at age 65, when you're choosing your Medigap plan, there is a good chance you may have that Medigap plan for the rest of your life. Now you can change, but again, there's no guaranteed issue. So when you're first enrolling at age 65, it's an important decision. Next question is, after age 65, how long after you lose your job and coverage with your employer do you need to buy Plan B, Plan D, et cetera, et cetera? After age 65, there's two enrollment windows that you want to be aware of. If you're not working or you're going to be retiring right at age 65, the initial enrollment window for those folks is a 7-month window, and your birthday month is the middle month. So you're looking at your birthday month, the 3 months before and the 3 months after. If you're transitioning to Medicare right at age 65, that is your initial enrollment window. I would suggest using the 3 months leading up to your birthday because you don't want to miss that window. Now, if you work beyond age 65, say you work to age 66, 67, 70, whatever the case may be, you will have a special enrollment window. And the special enrollment window is an 8-month window beginning with the month you terminate service from your employer. And again, something that you probably want to enroll in Medicare right at the beginning of that 8-month period, because it can take a month or two before your Medicare benefits to actually kick in. But if you're working beyond age 65, it would be the special enrollment window, which is 8 months beginning with the month you terminate service. The next question is, if I sell my home, the gains can affect my Part B premiums. Is that true? So the IRS is going to look at your modified adjusted gross income. And I probably should have prefaced the call by saying I work at a mutual fund company. I'm not a CPA or a tax attorney. I think if you Google modified adjusted gross income, it may give you a laundry list of what's factored in there. So I'm gonna have to take a pass on that question, but they do look at modified adjusted gross income, and I think if you cannot find that information, if you call EBW this afternoon, I think they'll be more than happy to dig that up for you.
Okay, well, I hope you've enjoyed today's presentation and you've learned a lot about health care planning and retirement. Thank you, John, for your time, and thanks to all our listeners for joining us today. We intend to have this as a replay on our webinar this webinar on our website within probably a week or so. Also, please be on the lookout for our next webinar, which will feature mid-year economic updates. Again, thank you for your calls, and we look forward to having you at our next webinar.